All right, guys, let's go ahead and get started. This is a quick overview of bulimia nervosa. We're going to talk about both the physiology as well as some acid-base changes, and we'll wrap it up with some clinical info. So before we get started, obviously, eating disorders, we could talk about this for hours. Today's discussion is more geared towards getting multiple choice questions correctly. We won't be going in depth on management. So a good definition of bulimia nervosa, there's a few things to look out for. Obviously, you have lots of overeating, but crucially, you cannot diagnose bulimia without purging. So this is going to help us distinguish it from both anorexia and binge eating disorders. A good thing to look out for on exam questions, if the patient has a BMI less than 18.5, you're dealing with anorexia. You cannot be bulimic without a normal BMI. Another thing to look out for, and this is what you'll be tested on, is some of the acid-base changes. So if you think about someone who is vomiting all the time, you're losing hydrogen chloride ions. This will cause a metabolic alkalosis. We'll go a little bit more in depth on this because they'll ask you questions about this. Treatment is first to stabilize the electrolytes. Then you're looking at cognitive behavioral therapy and SSRIs. This is more of a visual format. This is the DSM-4. I find it a little more helpful than the newer DSM-5 because it's a shorter definition. So they're binging more than twice a week, and they have a poor body image. Quick summary of the metabolic state in bulimia. This is really what your questions will come from. So like I said, we have that hydrogen ion loss. This is causing a metabolic alkalosis. Because of the dehydration from constant vomiting, you're going to have an aldosterone activation. This causes sodium reabsorption and potassium loss in the urine. Now, this is kind of a higher level concept. But once you start losing potassium, your body wants to reabsorb it. So that compensation causes acidic urine because you're trading potassium for hydrogen in an effort to prevent life-threatening hypokalemia. Just integrating this. So when we think about other causes of metabolic alkalosis, typically it has to do with the kidneys. You're almost never going to see metabolic alkalosis that isn't some sort of kidney disorder. So typically what we want to look for is figure out if we're dehydrated or fluid filled. And going off that, we might check the urine chloride or the renin activity. This is just trying to broaden our understanding, but not really relevant to today. This is how you tell between anorexia, binge eating disorder, and bulimia. First thing we're going to do is check the BMI. If they have a BMI less than 18.5, like I said, we can't even begin to think about bulimia. We're then thinking about anorexia. Now, if they are having an elevated BMI and they frequently binge, we need to figure out if they also purge. So if they binge and they purge, then we're diagnosing bulimia, which is what we're talking about today. This should be differentiated from binge eating disorder, which presents a little differently. The key with binge eating disorder is the person doesn't think there's anything wrong with their body. They really love to test this one. So they won't say Russell sign, but they'll say that there's bruising or scars or excoriations on the knuckles, so the MCP joints. And this is because if you think about how someone induces vomiting, they stick their hand in their mouth. And so you end up cutting them on the teeth. This is more so seen in anorexia, but one thing to look out for is lanugo. These are fine body hairs. People think that in malnourished states, the body has a hard time maintaining temperature, and therefore these little hairs grow. I'm sure the real reason is much more complicated, but if you see someone with new fine body hairs, you need to be thinking about anorexia or bulimia. They really love to test this one. It has to do with vomit coming up from the esophagus and infecting the parotid glands. So when you see bilateral parotid enlargement, this is pretty specific for anorexia. Now, you might remember with unilateral sialadenosis, you treat it with antibiotics. But when it's bilateral, you just hydrate, you apply a warm compress, and you have them suck on lemons. Now, the whole point of bulimia is that someone is purging. Purging doesn't just have to be vomiting. It can also be laxative use. And so in people with laxative abuse, one thing you can see is melanosis coli. So what this is, when you have a specific laxative called senna, it causes the epithelial cells in the gut to die. When they die, they leave behind pigment. So therefore, you see this leopard spotting, melanosis coli. Typically, when you have diarrhea, this causes metabolic alkalosis. So typically this causes an acidosis, but this varies based on concurrent vomiting. So laxative use, you shouldn't think of a specific acid-base disorder, but just know that it could be one of a few. Like we talked about with surreptitious laxative use, if you have a magnesium-based laxative, this will cause hypermagnesemia. If you have just laxatives, you'll have a metabolic acidosis, and if you also have vomiting, the ABG could show you anything. Just a reminder of other ways to do this. Someone could be injecting insulin, someone could be abusing diuretics, or using exogenous thyroid hormone. You can buy thyroid hormone on the internet for about $50, so I would look out for it being more common as the supplement industry grows. When we think about treatment of bulimia nervosa, there's a few things. The most important thing is fixing the electrolytes. If someone's potassium goes too low, they could have sudden cardiac death. The only FDA-approved medication is fluoxetine, but you can really use any SSRI. This has to be in conjunction with therapy. Thinking about the effects of bulimia on the kidney, the dehydration will cause aldosterone elevation. This should let you answer pretty much any question, but if you think about what aldosterone does in the kidney, it's going to cause reabsorption of sodium, and so you're going to have less sodium in the urine, and you're going to start secreting potassium. This will get into some of the clinical stuff. One higher level concept is called paradoxical aciduria. So if we think about it, vomiting gives you a metabolic alkalosis. So you wouldn't expect acid loss in the urine. The reason this happens is because as you lose volume, you have aldosterone activation. Aldosterone activation causes potassium loss in the urine. Potassium loss in the urine, therefore, causes more hydrogen ion loss as the body tries to hold on to some of that potassium. This really gets too complicated, but all you really need to remember is that the body loses potassium, and in trying to hold on to it, tries to excrete hydrogen ions. And so the urine gets more acidic. One thing to know is when you have someone who's dehydrated, oftentimes you're going to give them IV fluids. The most common IV fluid is normal saline. Normal saline causes a metabolic acidosis. This can be beneficial in this context because it improves our ABG results. The reason for the metabolic acidosis, if you think about the urine over here, you're introducing a lot of chloride ions from the sodium chloride. Chloride is reabsorbed in exchange for bicarb, so you're peeing out more bicarb. When you do this, you get more acidic, causing a metabolic acidosis. Now, all this acid-base stuff might seem low yield, but I got a question on this the other day where you basically had to understand that once you have someone who's been vomiting a lot, because of aldosterone, you will have low urinary sodium. So this isn't as niche as it sounds. One thing to look out for, if you have someone who's been purging a lot, let's say they haven't eaten a few days, If they suddenly have a large meal, what happens is they have a sudden surge of insulin. This causes lots of metabolism and it causes dangerously low phosphate levels. This usually makes people feel lousy, but in addition to the phosphate, if you also have hypokalemia, you can have QT prolongation and sudden death. Another thing to look out for is that refeeding syndrome in someone who has bulimia sometimes can look just like a person with chronic alcoholism. So if you suddenly have a giant insulin spike and you suddenly have a lot of food intake, you might precipitate vitamin B1 deficiency. And so you can see Wernicke encephalopathy in someone who has refeeding syndrome. So really the key is they'll suddenly get confused and they'll have nystagmus. So in summary, bulimia requires a BMI over 18. You're going to have hypokalemic metabolic alkalosis, and you're going to have increased potassium loss in the urine. Treatment is with electrolyte management and SSRI. Thank you guys.